If it's not there, you continue, sir.
Okay. Again, I invite this young, energetic Dr. Vikash Singh, who is always present in any meeting of CCDSI and API. He is a wonderful speaker, and he is going to talk on a wonderful talk, that is RD or S inhibitor or ARB in heart failure. Which one first? Because please take over.
Thank you so much for the introduction, sir. Very good evening, everyone, and sincere regards to all my seniors and teachers. To be honest, when I first saw the topic, I thought, well, the answer is so obvious, and I think many of you would be thinking the same way. We definitely have a better molecule in the form of ARNI that is now available. Over next 15 minutes, I would be taking you through the journey of ARNI, how beautifully it has emerged as a molecule and is expanding its place in different spectrum of heart failure patients, not just chronic heart failure patients. And the evidence is also for its use in different patient population. So that would be exactly my work in next 15 minutes. We know heart failure is a significant morbidity as well as mortality burden across the globe. Nothing new regarding that. And there are large RCTs which have proved beyond doubt that inhibiting the RAS system and inhibiting the sympathetic nervous system is going to improve outcomes in patients with heart failure and reduced ejection fraction, what we call as HFrEF patients. Now, over time, there have been some wonderful molecules which have emerged in managing heart failure patients: ACE inhibitors, beta blockers, ARBs, ivabradine, MRAs. But in spite of using them all in the optimum way, the high mortality in heart failure persists to the tune of 50% within 5 years of diagnosis. And that is the reason why we keep on looking for better molecules to address this unmet need. Now, as I said, sympathetic nervous system blockage by beta blockers as well as RAS inhibition by either of the molecules which are described here has been in use. The latest addition is targeting the neprilysin inhibitors, and they enhance natriuretic as well as other vasoactive peptides and thereby cause various good effects, I would say, to the heart failure patients. Now, many of us are of the view that when we are combining valsartan and sacubitril, if we are using valsartan alone, it should be giving, if not equal, many benefits to our patients. Well, there are certain actions of valsartan, certain of sacubitril, and there are certain actions which take place only when these two molecules combine. So reversal or reduction of left ventricular extracellular matrix remodeling and reduction of cardiomyocyte cell death. This process is activated on a molecular level only when we have both of these molecules present in the patient. Coming to the trial which established ARNI, paradigm heart failure. Now, this was a landmark trial because it ensured a benefit over standard of care in enalapril. It was not a placebo-controlled trial. We were comparing it with ACE inhibition, which has been a standard of care for a very long period of time. And look at death from cardiovascular causes, around 20% reduction over enalapril. Talk about first hospitalization for heart failure. Again, 21% reduction over and above what was being given by enalapril. And not only that, death from any cause, around 16% reduction. So it's not just the 20% over and above the ACE inhibition that sounds interesting here. It is also the fact that we have compared it, or we have gained this advantage over and above what we were able to get from before. So I would just make you look to the extreme right of this slide, the p-value. Every p-value in primary composite endpoint is significant. You talk about death from cardiovascular causes or first hospitalization, or death from cardiovascular causes, or individually even first hospitalization for worsening heart failure. Even the secondary outcomes, death from any cause, is significantly in favor of ARNI compared to enalapril. And look at the side effect profile, or new onset atrial fibrillation or decline in renal function, where it is as good as the standard of care. Now, looking a bit deeper into paradigm heart failure, we would be interested to see which are the patients who were benefited so much, because heart failure in itself is a complex group of patients. So just look at the key enrollment criteria for paradigm heart failure. Now, these were patients of more than or equal to 18 years of age, NYHA class 2 to 4, ejection fraction less than or equal to 40%. Now, they were either having a prior heart failure hospitalization, or if not, they had a higher BNP and NT-BNP, NT-pro-BNP cutoff levels. eGFR was more than or equal to 30. Systolic blood pressure was more than or equal to 95. So they had some BP margin to play with these molecules. Potassium level was less than or equal to 5.4. And the most important part is right at the bottom. Now, all these patients in paradigm heart failure had a run-in period with active treatment. So they were receiving either ACE inhibitor, enalapril 10 milligram per day, or equivalent for 4 weeks prior. And that was probably the reason why many of us got into the habit of starting with an ACE inhibitor or ARB first before switching our patient to ARNI. This was a very interesting article that I found yesterday only. Is the paradigm heart failure cohort representative of the real world heart failure patient population? And just look at the line that I have highlighted. Combining the inclusion and exclusion criteria of paradigm heart failure, around 25% of patients with systolic heart failure, by definition, they have included ejection fraction less than or equal to 50%, and 42% of patients with HFrEF would be eligible for a paradigm heart failure. Now, here is the catch. You have a trial which has established ARNI, but it represents only 42% of the heart failure patients. So what about the other heart failure patient population? Is ARNI as useful in those patient population as well? We'll be having a look. Now, if we look at acute in-hospital initiation of heart failure therapies, now universally there is the paucity of evidence for any molecule you talk about, ACE, ARBs, MRAs, beta blockers. We do not have a very good representation from benefit of in-hospital initiation in these group of patients. Fortunately, there are certain trials with sacubitril valsartan in patients following an episode of ADHF, and these were in last 2-3 years, the Pioneer Heart Failure as well as the Transition trial. The Pioneer Heart Failure, this was presented in 2018, and it included patients hospitalized with acute decompensated heart failure with ejection fraction of less than or equal to 40%, and they were randomized in a 1:1 fashion to either an ARNI or enalapril. And the primary endpoint was looking at the NT-pro-BNP levels. In the ARNI arm, there was 46.7% reduction in NT-pro-BNP, whereas in the enalapril arm, there was only 25.3% reduction, and the p-value was significant. So this is an indirect correlate, I would say, that this is offering benefit to our heart failure patients, even when they are admitted in the hospital with acute decompensated heart failure. And not only that, there are certain other highlights from the Pioneer Heart Failure trial. Although hypotension was more common in the ARNI arm, even the patients who developed hypotension when the drug was used in smaller doses, they would be benefited from sacubitril valsartan more than enalapril. The rates of worsening renal function, hyperkalemia, symptomatic hypotension, or angioedema overall was similar in the two groups. There were fewer heart failure related adverse events in patients assigned to sacubitril valsartan. So all of these point towards, I would say, a confidence in using this molecule while the patient is in the hospital. Look at the design of the transition trial. Now, these were again including patients for acute decompensated heart failure, HFrEF patients only. And there were 3 strata of patients. One patient population was receiving ACE inhibitor with OMT. Second was receiving ARB. Third is an ARB naive patient. And what we did, we initiated ARNI in one group of patients more than or equal to 12 hours before discharge and less than 7 days post randomization. So we basically were trying to look at whether we can start ARNI in the hospital setting or after discharge only, which strategy is safer. And safety outcomes was similar for each strategy, indicating no disadvantage to early initiation. So if you are using this drug, even in the ICU or hospital setting, well, nothing against it. This is what came out from the transition trial. And very important thing would be a meaningful proportion of patients in pioneer heart failure, around 53%, and in transition heart failure, around 24%, were ACE inhibitor and ARB naive patients. So even patients who have never received an ACEi and ARB, and we were straight away starting them on ARNI, were receiving all the benefits of ARNI. So starting with ACE-ARB is not at all essential, even in this patient population who were being started while being hospitalized. And there was a subgroup analysis of the transition study, which looked at how the two group of heart failure patients behaved. One was de novo heart failure patient, and second was chronic heart failure with reduced ejection fraction patients. And it was interesting to see what happens is we are many a times skeptical in using a very potent molecule or a new molecule when a patient has been diagnosed as heart failure for the very first time. If we are knowing that this is a patient of heart failure who has presented now, probably we would be very comfortable using this molecule. But for the first time diagnosis, many of us would be thinking twice. So this trial, or rather the subgroup analysis, would strengthen your confidence that more de novo than prior HFrEF patients achieved target dose at week 10, and fewer had adverse events and permanent treatment discontinuation. So this was just to establish the safety. And based on these trial data, after acute decompensated heart failure, first-line initiation of ARNI in de novo HFrEF patients alongside the initiation of other guideline-directed therapy is feasible and is associated with a better risk-benefit profile than in patients with prior HFrEF. This came up in the European Journal of Heart Failure 2020, last year only. And early intervention with ARNI may be considered to delay disease progression even in patients with de novo HFrEF. And just, I would be quoting few lines from European Journal of Heart Failure 2019. It says that initiation of ARNI rather than an ACE or ARB may be considered for patients hospitalized with new onset heart failure or decompensated heart failure to reduce the short-term risk of adverse events and to simplify management. Again, ruling out a strategy that we need to start with an ACE or ARB first. Now coming or addressing the more important part, what happens if we are starting ARNI in hospitalized HFrEF patients without ACE or ARB exposure? Are we getting all the benefits? So this is a comparison between two arms. Yes, ACE-ARB means patients who were receiving ACE-ARB from before, and no ACE-ARB means we have introduced ARNI for the first time in ACE-ARB naive patients. And look at the magnitude of reduction in rehospitalization for heart failure. So 48% reduction in heart failure rehospitalization, even in patients without prior exposure to ACE-ARB. Similarly, 46% reduction in cardiovascular death in patients without prior exposure to ACE-ARB, and this was more compared to patients who were receiving ACE-ARB from before. Sacubitril valsartan again reduces serious clinical composite endpoints to the tune of 48%. So it's a comparable benefit in patients who have not received ACE-ARB from before, and the similar magnitude of benefit even in terms of NT-proBNP reduction was seen even in patients who were not receiving ACE-ARB from before. So ARNI has shown a paradigm shift in the management of heart failure. In paradigm heart failure, we were targeting the outpatients only. We were trying to keep them improved so that the chances of hospitalization is reduced. But even if our heart failure patient is hospitalized, we now have data in form of pioneer and transition trial that we can use this molecule safely in in-hospital settings, and the benefit is outstanding. So whenever we are talking about heart failure, we always say discharge is not the end of journey of a heart failure patient. Rather, it is the start of the journey. And so when we are discharging a patient of heart failure, we should be taking, or rather we should be giving all the molecules which have shown to improve rehospitalization rates for these patients. Now, another area of concern for anyone, whenever we are talking about a newer molecule, is the safety profile. People would ask, is it as safe as my old standard of care? Well, we have enough data now to compare it with ACE or ARB, and adverse events are similar between the two arms, no matter you are using an ARNI or ACE inhibitor or ARB. Well, there are certain areas you need to take care about, like the potassium levels, like the declining renal profile, like postural hypotension, but otherwise, no other safety concerns when you compare it to ACE inhibitor or ARB. And again, irrespective of prior ACE or ARB exposure, it has been found safe and well tolerated across all the adverse events that it has been tested for. Now, a few words about Paragon heart failure. In fact, just prior to my discussion, we had a wonderful few lines about HFpEF patients and ARNI. Yes, sir was right that it has very recently now been, I would say, permitted to be used in HFpEF patients. See, HFpEF has been the most difficult area in heart failure management because for a very long period of time, we have been looking for that molecule which can actually help in managing these patients. But apart from targeting the risk factors and targeting coronary artery disease, controlling the heart rates in AF patients, there isn't actually a good molecule which can take care of HFpEF patients. Now, ARNI went closest to giving us some benefit. Although primary outcome was not met, the p-value was not significant, but when you talk about the numerical values, there was significance in favor of ARNI compared to valsartan, and that was the reason why many in FDA advisory were of the favor, were of the view rather, that it should be given a go ahead, and that was the reason it has now been recommended to be used in HFpEF patients. It would be interesting to see how actually this molecule behaves. Now, a few lines or a few slides just to show how this molecule actually acts over and above the mechanism of action that we have just discussed. So there have been many trials. One is short-term echocardiographic evaluation by global longitudinal strain. So GLS is not a new parameter. The systolic functions is measured by various parameters. Ejection fraction is the most crude of them, but the most commonly used. So if you start using ARNI, you are going to get early markers of benefit in terms of left ventricular remodeling, which can be captured by myocardial strain. So even if EF is not improving, you can get an idea that systolic function is improving from GLS, and this effect is more marked with ARNI compared to other groups. The sickest of patients. Now, beneficial acute hemodynamic effects of ARNI in patients with low cardiac output. All of us would agree that this is a very difficult patient population, heart failure, low cardiac output, and even using ARNI in this group of patients has shown promise. ICU patients can be successfully bridged from vasoactive IV therapy to oral ARNI with sustained hemodynamic improvement. Although these are very small trials, not trials, but rather case studies or observations, I would say. But this is one area where, again, ARNI has shown promise. ARNI also improves RV function in patients with chronic heart failure, and that is, again, something that makes it very interesting. Not just the LV function, the RV function also gets improved. Even in patients who are waiting for heart transplant, till the time they are going ahead for heart transplant, we can use ARNI, and ARNI shows a rapid improvement in physical frailty in heart transplant waiting list patients. So till the time we are actually going ahead with heart transplant, we can offer them certain advantages from ARNI. Now, before I finish, just a quick word about another trial which has just come up or which has just been presented. Now, this is something good for ACE inhibitor liking physicians or cardiologists to actually cheer about. This is Paradise-MI trial, just been presented in ACC 2021. Although this did not actually enroll heart failure patients, but acute myocardial infarction patients within 7 days with ejection fraction of less than or equal to 40% and pulmonary congestion. Plus there were certain risk enhancers, and they compared ARNI versus Ramiprila head-on comparison without any run-in period. And the primary outcome, well, ARNI did not score superiority over Ramipril, although numerically the events were less in ARNI arm, but p-value was not significant. Although there was certain other indices or markers where ARNI would seem to be faring better compared to ACE inhibitor. But as of now, ACE inhibitor had been found to be as good, or in other words, I would say ARNI does not score over ACE inhibitors in this post-MI group of patients. If we compare the adverse events, ARNI fares as well as ramipril. So just to summarize this Paradise heart failure, so this is a very interesting trial which will have some implications in times to come. But this trial has implications for both the physicians who prefer ACE inhibitors as well as physicians who prefer ARNI. ARNI people would say that numerically we were better with a similar side effect profile. ACE inhibitor loving people would say that we have a molecule which is holding strongly against an ARNI. So let's see where ARNI goes from here. But it's for sure that in times to come, we are going to get more and more evidences in support of ARNI, and the users of this molecule, fortunately, hopefully rather, will pick up in times to come, because this is a wonderful molecule, no doubt, but the uses remains largely low. Thank you so much. Thank you so much for the patient hearing.
Thank you very much, Dr. Vikash. It was as expected, wonderful talk, and you have made a point in favor of ARNI. Now, I allow one or two questions from the House to discuss about this ARNI or any other better proposition.
Comment here, please. With due permission of Dr. Deviram, Chairperson. Dr. Vikash, it was an excellent talk. And when initially I gave you the topic, I knew you were reluctant to take this topic. But see, after the Paradigm HF trial, there was a study which said that despite the excellent benefits showed by ARNI, hardly 20% of the patients of heart failure are on ARNIs. And they said that we do a lot of good trials and good evidence we get, but unfortunately that is not translated into clinical practice. And you have very rightly shown. Now, a word about the Paradise MI trial. Of course, it was a big boost for the supporters of ACE inhibitors, because they said that at much lesser cost, you are getting the same benefit. But they agreed to the limitation that these patients were post-MI patients and did not have any evidence of heart failure. So there is no doubt that we cannot forget the evidence given by Paradigm HF trial. Now, as far as HFrEF is concerned, we all know there are 4 pillars of treatment. One is, of course, the ARNIs, as I personally believe they are superior to the ACE inhibitors. And number 2, of course, the MRAs. Number 3, the beta blockers. And number 4, today, the SGLT2 inhibitors. So all 4 have to be started either almost one after the another or simultaneously. And within 15 to 20 days, the patient must be receiving these 4 drugs after discharge. That is the current concept in the management of heart failure with reduced ejection fractions. Dr. Abhay Krishna has joined. Dr. Abhay Krishna, your comment, please. Is Abhay there?
Yeah.
Dr. Birmani.
Good evening, everybody. Sorry for the connectivity problem. Excellent presentation, Vikash. And
yes,
definitely,
1 minute.
we have the option.
Yes,
Definitely,
Doctor.
Option of ACE inhibitor, ARB versus ARNI. So what we see in clinical practice, ARNI is an excellent molecule with acceptable safety profile. And about the last trial he mentioned, I think in heart failure with reduced ejection fraction, if the patient is already on ACE inhibitor ARB, you can switch over to ARNI, or if no ACE inhibitor ARB is being given, then you can straight away start with ARNI.